session. I am joined here today by my colleagues at the Pacific Institute for Research and Evaluation. We have Elika Whitney, who will facilitate today's discussion. But before I turn it over to Elika to introduce our guests and get started with today's program, I just wanted to share a little bit of information about the center in case this is the first time you're joining us. And towards the end of the slide deck, there will be a QR code. If you're unfamiliar or not receiving our monthly newsletter yet, you'll have an opportunity to sign up and get notified of future events. Sophia, thank you so much. All right, so in a nutshell, the center exists to really support those system change efforts that help communities identify what their local prevention needs, and more importantly, evidence-based local prevention solutions are, and the options that are available to them. We really work to enhance those multi-sector efforts to support Ohio's children, adults, families, all individuals across the lifespan. And hence we are very excited. I think today's topic and our speakers are a great example of where prevention and education can come together to support kids. And then finally, we strive to advance the use of prevention science for mental, emotional, and behavioral health prevention and promotion.
No.
So we're really glad you're here. I'm going to go ahead and turn it over to Elika Whitney, who is going to introduce our panelists who are joining us today and take the program away. Thank you so much, Elika.
Thank you, Jen. Good afternoon. Yes, if you have not had the chance to meet me yet, my name is Elika Whitney, and I am a program manager with the Pacific Institute for Research and Evaluation. I'm thrilled to be sitting in for Dr. Tessa Miracle today. She typically gets to moderate these prevention exchange sessions. And I'm really excited to get to have a conversation with Reem and Catherine about exploring the role of school-based health centers to foster protective and compensatory experiences or PACEs. So for the format of our afternoon, we're going to begin with some presentations and insights from Reem and Catherine around those school-based healthcare centers. And then we're going to go into breakout rooms as a few different small groups where a couple of questions for you all to discuss will be provided. And then finally, we're going to come back together to wrap up our time. So just as a reminder, the large group session is being recorded, but when we go into those breakout rooms, we'll stop the recordings to give everyone the opportunity to have a little bit more candid conversation within that space. We really want to encourage you to learn and grow from each other during this time and really deeply explore the questions and maybe any uncertainties you might be having. So without any further delay, I'm going to hand the mic over to Reem and Catherine. They'll do brief introductions of themselves and then get started.
Good afternoon, everyone. And that was a flashback in time. That's maybe a decades old picture of me. But really, really happy to be with you all today. And I'll introduce myself, Reem Ali. I am the Executive Director of the Ohio School-Based Health Alliance. And I have with me Catherine Bissett, who is part of the Ohio School-Based Health Alliance team officially now. She is actually our Director of School-Based Healthcare Initiatives. And I'm going to go ahead and share my screen, but want to just give Catherine the opportunity to introduce herself.
So good to be here today, and it's really fun to see a lot of familiar names of our friends and partners on here. So thanks for coming. Yeah, this is my first engagement as an official member of the Ohio Alliance team. So I've been working with Reem for about a year as a consultant, and I'm now coming in-house. And I'm really excited to continue our work supporting our partners around the state and to get to present to you about how school-based health centers are a protective factor against adverse childhood experiences today. So thanks again to the team for inviting us.
Thanks, Catherine. Thank you again to the Ohio Prevention Network team for having us present. I just wanted to give a brief overview of the Ohio School-Based Health Alliance. If you're not familiar with who we are, we're a statewide professional, nonprofit, nonpartisan organization that was created to advance and support school-based healthcare in our state. We were founded in 2002 as the Ohio School-Based Healthcare Association, and after a period of really more regionalized focus, we relaunched in 2021 as the Ohio School-Based Health Alliance. And then we have been the designated state affiliate of the National School-Based Health Alliance since 2010. And just excuse me while I navigate a couple of different screens and sharing at the same time. Our organization's vision is really predicated, as you can see, on ensuring that students in Ohio achieve optimal health and education outcomes. We recognize that we are one of many organizations in our state that are contributing towards this vision. And our mission is really solidly focused on improving access to comprehensive integrated health services through school-based healthcare to improve outcomes for our students, families, and communities across the state. We couch our work in the 3 buckets that you see here. Capacity building, which includes technical assistance, learning collaboratives, providing guidance, resources, toolkits to our school-based healthcare partners, which are primarily our healthcare provider partners and school district partners, but we also work with both state and community-based organizations. Then policy transformation, which is just a fancy way of saying education and advocacy for strong policies that support school-based healthcare, and then data transformation. So we are undertaking building a data hub or infrastructure for our school-based health centers and other school-based healthcare partners. These are the objectives that we'd like you to come away with from this presentation today. And so our hope is that you have a better understanding of the current landscape of school-based health centers in Ohio, that you understand the role school-based health centers can play in positively impacting or promoting positive childhood experiences, and that you are able to think about the various ways in which school-based health centers can benefit the communities that you serve. All right, so just to go ahead and dive into it, I'd love to just give you a little bit of a lay of the land around why we think that this model is so incredibly important. I am a data person at heart, spent years focused on the data, and so always like to start off with the data to lay a foundation for the work that we're doing. And what we know in Ohio is that our students are really facing significant health and education challenges, and those challenges have been exacerbated over the past few years. And these are a few data points that highlight what this looks like. We know that 1 in every 8 children in Ohio are struggling with depression or anxiety, and that was as of 2020. We know those numbers are even higher today, and that's a 42% increase since 2016. And then when we take a look at our education challenges, just in the past school year, so the 2022-2023 school year, we found that 1 in every 4 K through 12 students in Ohio was chronically absent, which means that they were missing 10 or more days of school a year. We also know that many of our students do not have access to comprehensive and timely healthcare services. 1 in 5 don't have a place to go when they are sick or a usual source of care. And for adolescents that are enrolled in Medicaid, barely half are receiving their well child visits. And this brings us to the model that we'll talk about today, and that's school-based health centers. And this is a evidence-driven model for advancing school-based healthcare and improving health and education outcomes. These centers are created through a partnership between a school district and a healthcare provider to increase access to, at minimum, primary healthcare services to students on a school campus. And I'll share some additional information about how these models might differ across the state. What's important to understand is that this is truly a partnership model. The healthcare provider will serve as the operator or the administrator of the school-based health center. They are the entity that employs the staff that provide the healthcare services in the school building or throughout the school district, but they have to work very closely with their school district partner to ensure that student needs are met. At its base, what a school-based health center does is remove student and family barriers to accessing care. And some of those are highlighted here on this slide. Working parents or guardians may face challenges if they're unable to take time off of work, or maybe lack transportation. And so by making healthcare accessible and overcoming these barriers, school-based health centers have really shown strong evidence for improving student health and education outcomes. I'm going to share a series of slides now that provide you an overview of the school-based health center landscape in our state. We just recently completed a 2023-2024 school year census to verify where school-based health centers are located in Ohio, and I'm going to share some information from that census. So through that census, we were able to verify that there are 135 school-based health center sites across the state. These are physical locations within a school building through which primary care services are being delivered by a healthcare provider. The map that you see here identifies the counties in the state where we see at least one school-based health center site. Now, the caveat that I will share is that many school-based health centers also operate what we call a hub and spoke model. So while they are located in one school building, they're actually serving other buildings within the district. So this doesn't capture, the 135 number does not capture the number of school buildings that are actually served by a school-based health center. So we find that those numbers are going to be higher. We've seen really an incredible growth in the in the startup of school-based health centers across the state, and in the existence of these models across the state. So you can see that really kind of this started back in 1994, the mid-90s, and then just over the past 5 years, we've seen a pretty rapid increase. So 2019 to 2024, 62% of the school-based health centers in our state were established. And there are a number of different reasons for that, but funding was certainly a big component of that. Here you see a breakdown of the various services that are offered by school-based health centers. So again, the way the Ohio School-Based Health Alliance defines a school-based health center is that at minimum, it provides primary care services, but many also offer numerous other health services for health-related services. So you'll see behavioral health is at the top of that list, and many of our sites also provide dental and vision services as well. And then this is a breakdown of our site's service of patients. So what does the population that these school-based health centers serve look like? Again, 100% serve students per the definition of a school-based health center, but many also serve the families of students, school staff members, and or might be open to the broader community. And this is really determined by the healthcare provider that is sponsoring the site, so that is operating the school-based health center, and the school district partner, and what the community needs are, and what they look like. Okay, so so from here, what I'd like to do is just give a really quick overview of ACEs, and then Catherine's gonna give you some really great examples of how school-based health centers can really mitigate and or support positive childhood experiences. So I know many of you on the call are already familiar with what adverse childhood experiences are, so I won't spend too much time on this. But we'll just kind of give you the high level definition, which is that these are traumatic events that occur during the childhood years of a person. So usually we kind of say ages 0 to 17, but of course, it could be a little bit longer than that. And there's quite a bit of variation actually among researchers in what is considered an ACE, but these are the 3 most commonly grouped categories of ACEs. So we usually talk about ACEs as far as abuse, household challenges, and neglect. And something that I did in my past life was really research the impacts of ACEs. And what we know is that these adverse childhood experiences are quite pervasive in Ohio, and that they have incredibly hefty health and cost implications. one of the things that I always like to say when I'm talking about ACEs is that not every child that is exposed to ACEs has to suffer from poor health and education outcomes as a result of their exposure to ACEs. And there are protective factors that can have really a mitigating effect on exposure to ACEs and diminish those negative impacts. And we're gonna talk a little bit about what that looks like in a school-based health center setting. But here you see the list of both the risk factors, so the factors that contribute to a child's exposure to ACEs, and then also the list of protective factors. And I'd be remiss if I didn't call out my my former organization, the Health Policy Institute of Ohio, that's done some pretty incredible research on this. And here I'll highlight where we like to focus the rest of our presentation. So we've spotlighted here where school-based health centers really have a alignment to the protective factors that can promote positive childhood development. And so I will hand it over to Catherine to talk more about these protective factors that are promoted by school-based health centers.
Thanks, Reem. Yeah, so I think as you saw on the map that Reem shared, we have school-based health centers all over the state, but you also saw that she said 1 in 5 kids don't know where to go when they're sick. And those are the places that school-based health centers tend to work best, right? While they're geographically diverse across the state, they're located deliberately to address healthcare disparities. They have the most success in areas where families are facing those barriers to care that she talked about and have unmet needs. Those can be urban or rural or suburban or name all of the above. But they have something in common that they've often been neglected by the healthcare system. And a lot of you on this call work in places like this, right? Where when jobs left and when grocery stores closed, doctors tended to leave too. So the existence of the SBHC model is a direct response to this underinvestment by the healthcare system and then recreates communities with healthcare providers, which we know to be a protective factor. So that co-location, when we say not only we're moving into this place, but we say we're moving into actually the community center that already exists, right? Schools are sort of the underpinning of our society, and they're a place where kids and families already feel comfortable. And when we put healthcare providers and all the wraparound staff that support school-based health centers into schools, that's a statement of commitment. That sort of flips the old model of healthcare in which we expect patients to make their way to the healthcare providers. We flip and we come to them instead. Making that investment in space, which I know some of you on this call have been through this, that's a significant investment in process, in staffing, and in that wraparound case management care, is really the demonstration on the part of the healthcare sponsor that they are working to address that historical neglect and that they're committed to the health of that community. She told us, right, that stat gets me every time, that even this year, 1 in 4 kiddos were chronically absent, and that 10 days is the minimum threshold. So we know lots of kids in our state are missing 30, 40 days of school a year. And there are many healthcare factors that contribute to that. So I say that school-based health centers have a bunch of superpowers. And one of their biggest superpower is reducing absenteeism and increasing seat time. So not only reducing the number of days a kid is absent, but increasing the number of hours that they're in their seat learning in their classroom. I think everybody on this call knows, right? We know that kids who spend more time in school are safer. They are more likely to read by 3rd grade, which is a national metric we really care a lot about. They're more likely to graduate on time. And all that leads to better health outcomes and increased learning through increased earning throughout their life course, right? We know kids that read at 3rd grade earn more as adults. So this absence prevention is done not only by solving for those 1 in 5 kids who didn't know where they needed to go, right? We have readily available, like urgent care visits, illness, injury visits, but also through this really robust management of chronic conditions that school-based health centers are able to do. So, the number one medical reason that kiddos are chronically absent is poorly controlled asthma. And rates of asthma vary widely in our state, but they're much higher in the neighborhoods that we're talking about. And if your kiddo has chronic or moderate, severe, persistent asthma, the recommendation is that you're bringing them for a checkup every 6 weeks. And even those of us parents on the call who maybe have a more flexible job and have our own transportation kind of laugh at that. Like every 6 weeks, a doctor's appointment, it's a lot. If you're working long hours at an hourly job where you don't get time off and you depend on public transportation, or you live in a healthcare desert, that's just completely unrealistic. So school-based health centers, that this superpower is that we see kiddos in school where they already are, where they need to be without their parents. So we're removing all those barriers and we're able to make adjustments to their care quickly, right? So take a kiddo who's been in the ED or the PICU 8 times last year, get their asthma under control, be able to respond to exacerbations in real time, and actually reduce their absences to 0. So many school-based health centers, as Reem shared, also have embedded mental and behavioral health, which is another real contributor to absence and untreated mental health care. Untreated mental health issues are trauma, right? They lead to ACEs. Untreated mental health in the home is definitely an ACE. So we know that embedding that mental health care right in the site is invaluable for families, is really protective for kids. You guys know that waiting for outpatient appointments in some parts of our state for mental health care can be months long. And that doesn't help you when your kiddo is in crisis that day. It supports families. It also supports teachers and school administrators, right, who have been pulled in a lot of different directions over the past few decades to try to be everything to kids. So having an expert right there in the school building to address mental health exacerbations and coach teachers and help administrators on how to work with kiddos who are struggling with depression or anxiety is another superpower. I think you guys can already tell, and those of you on the call who know me know I'm like a nerd. I could talk about this all day, but I'll highlight one more piece here on this slide. School-based health centers protect against ACEs by caring deeply about social drivers of health. So school staff, as you know, and school-based health center staff are often the first people that know of a family experiencing a social driver of health issue, right? A 3rd grader that comes in, slept in his car last night, high schooler that hasn't eaten over the weekend. They get that information first. You're familiar with this idea. I'm sure you've heard about this, right? All that category of things, social drivers of health that impact physical and mental health outside of this exam room. And what school-based health centers are increasingly doing is universal screening. So screening all the patients that they see for social drivers of health, and then having infrastructure set up to respond with help quickly for families who need it. And by doing that kind of work, even if it's not universal screening yet, even if it's just responsive to when you're hearing it, you're intervening before the trauma happens, right? So here in evictions coming, the healthcare organization jumps into work, partners with their community-based organizations. Preventing homelessness, we literally just prevented an ACE for that kiddo who was a patient of ours. All right, Reem, I think we can go to my next one. So I'm a nurse by training, and I was really lucky enough to run school-based health centers for the last decade before I moved to this role with Reem. And this is my favorite part of what we do. The people who choose to work in school-based health centers believe in the power of the relationships that we're building with our patients and families. So, what we aim to do well is form this triangle of support, right? The 3 different players that have the most impact on any kiddo's life are their family, the educational system, and the health system. And if you even just think about your own children, if you have them, those 3 systems oftentimes have a hard time talking to each other. Like it's hard to imagine your outpatient pediatrician getting your kiddo's teacher on the phone and talking about a learning difficulty that they're having. These are historically siloed industries that speak sort of different languages. So approaches to problems that really need to be uniform can be disjointed, or messages can get lost in translation, and kids end up suffering from that sort of ping pong game. So school-based health centers deliberately break down those walls And with the right consent form and the right releases, information can be shared really effectively, and then work is better aligned. So one of the projects I was really proud of that I implemented at a school-based health center that I ran was we saved the time of our medical director and pediatrician. Once a month, we blocked time on her patient schedule, and she actually went to student support meeting monthly so that all the school team grouped her patients at the beginning of the meeting, and she sat in for all the IEP and 504 meeting reviews and was able to contribute in real time, hear the issues that the school was having, inform some of their techniques with her medical expertise, make adaptations to her care of plan, her plan of care. And this was all able to be communicated to the parents as well. So it really was a nice, regular way for her to be super responsive in her medical care to the kiddos' experience in school. She even was able to observe some patients of hers in the classroom and see what was going on, and then be able to structure her care and the care of the rest of our mental health team based on what she'd seen. So that co-location enables this triangle, and it can be really powerful. The other thing I mean, there's many things I love, but one thing I loved in particular about working with adolescents is just being a strong relationship, a strong cheerleader for them that wasn't asking them to do anything, right? So like, think back, if you're raising teenagers or you all were a teenager, think back to the adults in your life when you were a teenager. Like, everyone wanted something, right? Your teacher wanted you to hand in your stuff on time. Your principal wanted you to behave a certain way. Your parents wanted you to clean your room. Your boss wanted you to be on time to work. Teenagers, I think, often feel like adults are just a living, like, we're just constantly telling them about their obligations. This relationship is different. This is just a supportive cheerleader, supportive adult in their life that doesn't have any criteria for what they have to bring to that relationship. And it's really unique. Because of that, I think because of the rapport that our school-based health center operators around the state are able to generate, school-based health centers end up being a really safe place for these hard conversations that teenagers need to have. They're often kind of the first stop for issues around mental health, around relationships, healthy relationships, around sexual and reproductive health care. And the way that clinical work is structured in a school-based health center is intended to give kids lots of opportunities to share their needs around this. So there's a wide range of practice norms here in the state of Ohio, but most school-based health centers are talking with adolescents about healthy relationships, right? About how to recognize red flags of abuse and about how to make good choices when it comes to their sexual and reproductive health. And that having the bandwidth to do that work gives us, as that safe, nurturing relationship, gives the adults in their life this enormous power to insert good lessons, right? To use motivational interviewing, to coach kids through hard decisions before they launch, before they're out of the home, and to have tough conversations to hold them to task when they're not making the right choice for themselves. So, I mean, I have dozens of stories to share in this arena, but one that really impacted me recently was I ran a school-based health center in an urban high school here outside of Cleveland where I live. And I was the first person that a high school student came to tell that her boyfriend was physically and sexually abusing her. And it was one of those moments where I really had to swallow my own tears and horror and anger and sort of jump into action and coach her through what we needed to do. It was messy and ugly, and thank goodness for the school district staff that responded really helpfully. Eventually, she was able to get a restraining order against that other student, and he was moved to an alternative education setting. But it was because of the relationship that I had built with her that she was willing to let me in on that, and that she was safe in the end, and actually just graduated in May and is going off to college. So for now, a really happy ending. And I feel that she's really well equipped in her future to recognize the red flags that she didn't before she was brave enough to come forward. So along those lines, right, the wraparound care that school-based health centers have the bandwidth to do, their co-location and the pre-existing relationships that I described to you often make them the first stop in times of crisis for kids and families. And that's an obligation that we take really seriously. So again, lots of stories. I've been the first person that several teenagers have told that they were pregnant or suspected they were pregnant. I had one a few years ago who was a sophomore in high school. She and her boyfriend had been hiding for several months that she was pregnant. So by the time that he walked her into us for a pregnancy test, she was into her third trimester. It was quite obvious. We were able to jump into action, get her first appointment done with us right in the school-based health center to confirm that pregnancy and to confirm a live baby. And then we're able to get her over to an OB that day. And into care. And then, our team jumped into action. We had, I'm sure many of you are really familiar with the community health worker model. We had a really strong community health worker that worked with her and her family. And in a short amount of time, sort of developed a plan and ended up getting her baby placed with a family who really wanted to adopt that lived right in our town. And she's still involved in that baby's life, visits him a few times a month. And it just wasn't an example of a level of wraparound care and nurturing and hand holding that she would not have gotten if not for the relationship with the school-based health center. And we were really proud of that. So Reem, let's go to my last slide on. So, as you can tell, I've touched on the relationships that school-based health center staff build with their patients, but this is another explicit SBHC superpower. Like, while we're doing all that work for kiddos right now, what they don't really realize is that we're also helping them develop these healthy social and emotional skills that they will use their whole lives. The access that those patients have to adult relationships free of expectations and really safe spaces and really patient folks is so protective. So I talked a little bit about flipping that old paradigm, right? That healthcare providers take off their white coats, come down from that hospital on the hill and show up in the cafeteria, right? That's the first step to dismantling the old hierarchical system. But it doesn't stop there. That's just the beginning. We say school-based health centers in our state vary so much that if you've seen one, you've only seen one. But the thread they have in common is that folks who choose to work there are self-selecting and they're actively opting into that model that centers that relationship with patients. The model as it's built allows for longer appointments, more case management, and more independence for adolescents. So some of my favorite work in school-based health centers has been on this self-efficacy piece, right? On getting teenagers to feel more in control of their own physical and mental health, like from as small as coaching kids through learning to pick up the phone and call their own dentist and make an appointment. Like that's a teachable skill, right? To going to the pharmacy to pick up your own prescription. That we've worked with kids from everything, getting better control over their diabetes, right? Reducing that A1C or better control over their asthma, using risk reduction techniques to diminish frequency of smoking or drinking or engaging in risky behavior. I've had 18-year-olds come to me and say, okay, I want to do all those childhood vaccines that my parents actually turned down. Before I go off to college, I want to get caught up. And that was their sort of informed decision about their own healthcare. And I have lots of former students who are now in college call and text me to proudly tell me, I scheduled a therapy visit all by myself and it's coming up and I knew I needed to do it because I was having these symptoms. Or I was starting to date this person and I saw these red flags that you taught me about and I ended it and I thought you would want to know. So those relationships and the model as it's built that allows such intensive personalized health education have lifelong impact. We know, right, that one major, you guys can all identify with this, one important factor in your own health outcomes is being able to really effectively communicate about your own health needs and advocate for yourself. And kids and families who receive care in a school-based health center become experts on that. So I'm going to quit on my soapbox. I love this model so much. I could tell you guys stories all day. Thanks for bearing with me. I know the team has some great breakout rooms and discussions for you to have. But I know if also, I'm sure team, if they have any questions for Rima, do you want to do that now?
Yeah, and I think that our hope is that Catherine could give you a little bit more of the real life experience in connecting to school-based health centers and what that looks like. And I think it's always helpful to hear those anecdotes. We're happy to take questions. I do just want to share a few slides that can get you better connected with the Ohio School-Based Health Alliance. So we do have partner quarterly meetings that are open to all who are interested, that are facilitated every quarter. So our next one is actually going to be well, I guess not quite fall, still kind of towards the tail end of summer, but in September. So if you're interested, we encourage you to join in on those quarterly partner meetings. If you are a school district partner or a healthcare provider partner, we do have a membership. So if you're interested in signing up to be a member of the Ohio Alliance, you can get additional information by scanning that QR code or copying that link over. And I think the Ohio Prevention Network team will make these slides available for all of you. And then just want to close out by saying that we have a biweekly newsletter where we share updates, resources for our school-based healthcare partners across the state, not just school-based health centers. We certainly recognize that there are other innovative and effective models of school-based healthcare that are also happening across the state, and we do support those models as well. So if you're interested in getting some continuous updates from the Ohio Alliance, please do sign up to our newsletter. And with that, let me turn it over to the Ohio Prevention Network team and stop sharing my screen. And happy to take questions if there's time.
All right. Thank you so much, Reem and Catherine. We will leave time at the end for some questions, but we will come out into breakout rooms for just 5 or 10 minutes here. But I just want to say thank you again for all that wonderful background and content. It's so helpful to know that all of these resources are available for school-age children, and even depending on the site, maybe their families and communities too, just depending on the needs. So, and it's really great to hear that Ohio is supporting this with quick action and resources. It's really wonderful to hear. So we are going to take, like I said, probably more than 5, but less than 10 minutes here in discussion and breakout room. We will provide these following questions in the breakout rooms, but we're going to ask everybody to kind of think about and talk about within the communities and schools that you serve, what factors may impede a child's relationship with and access to a healthcare provider. And then the next question is, from your own work and experience, what do you think is important for SBHC providers to consider when providing care to children who have experienced ACEs? So let me open up these breakout rooms.